It's my pleasure to introduce the next speaker, Professor Dr. Yasser Reda. He will give us a lecture about anesthesia and analgesia for shoulder surgery from anatomy to practice. Dr. Yasser is currently working as a senior consultant of anesthesia and chronic pain management at Hamad Medical Corporation, Qatar. He is the head of the interventional pain medicine and PACU in Hamad Medical Corporation. He's also head of block rooms of regional anesthesia and interventional pain. He is the course director of ultrasound-guided regional anesthesia and pain interventions. Dr. Yasser studied anesthesia and chronic pain management at the National Cancer Institute, Cairo University, Egypt, and he was awarded Doctor of Anesthesia and Pain Management in 2001. He has the Arab Board of Anesthesia and Intensive Care from Cairo University, Egypt. He also has a European Diploma of Anesthesia from Sweden. He has a European Diploma of Regional Anesthesia and Acute Pain, the EDRA, and he has a European Diploma in Pain Medicine from Dublin. He has also certification of intervention pain sonography, CIPS from the United States. He has Fellowship of Intervention Pain Practice, FIPP from the United States. He has ASRA, Bain, and musculoskeletal ultrasound certification, the ASRA PMUC from the States. He has an ozone therapy diploma. He has an American Board of Headache from the States. Also, he published many papers in the field of regional anesthesia and pain medicine. And he's a speaker and faculty in many local and international conferences and workshops in regional anesthesia, chronic pain, and difficult airway workshops. Dr. Yasser, the microphone is yours.
Thank you, Dr. Ahmed. Thank you for the army behind this work, especially Dr. Saad and Mr. Darawarish. In many times when I see in my clinic all the time, Bain clinic, I get about every day about a clinic about 20 patients. From this 20 patients, about 3 to 4 patients come for shoulder pain referred from the surgeon. We try first as a conservative management, injection, physiotherapy, and many of those patients can improve. But still one of those patients need a surgery. And usually this patient have a severe pain and this is affecting quality of life and sleeping and socioeconomic standard, and the life of patient would be miserable. Before to speak, this is my beautiful city in Ras Al Bar. I think most of you know this city. I hope one day to return back to retire there. I don't have any conflict of interest except for the ownership to join this excellent group. My agenda today, I will speak about introduction about anesthesia and analgesia for shoulder surgery, history, update anatomy. You can tell me how can you speak about update anatomy? Anatomy is a fixed sign. Unfortunately, it's not a fixed sign. From 2009, after innovation of ultrasound, we found many variation, many variation. What we think is that a fixed sign is not fixed sign. Also, an update of regional anesthesia modality, many procedure, many block coming to the surface, method of shoulder analgesia and the value of everyone, evidence of regional anesthesia and shoulder surgery, and home message. Really, it is a very big meal to eat in half an hour, so I will try to eat as possible as I can. So at the end of this presentation, this is a learning objective. You must have a planning for your patient to make a general or regional anesthesia, to be safe about your procedure, to know the complication, the pathway of every complication, and how to discover and how to treat, and to know the difference between regional anesthesia and general anesthesia, and to update your knowledge about anatomy and the regional block, and to know some new alternative as evidence base for blocks. Before to speak, you must know some fact about shoulder surgery and shoulder pain. Shoulder pain is one of the worst pain you can imagine, even post-operatively or just pre-operatively when you send to your clinic, because most of the time the pain is chronic and haven't went up phenomena, and you know that pain is miserable. Regional anesthesia is more better as a pain control than general anesthesia. And before to speak about this, you know, the bed shear position is more important than anesthesia and analgesia, because many hemodynamic and cerebral function can be affected and can lead to mortality and morbidity. As I told you, nerve block produce more better analgesia, And the operative pathway must be integrated to teach the patient to plan for intraoperative management and multimodal post-operative analgesia, which is agreed for most of the physicians now. And you must know before that pain is subjective. Pain may be underestimated all the time, and may be undertreated, especially with severe pain like shoulder pain. And you know the pain is like a monkey in your shoulder all the time. And this paper just to show that evidence that central sensitization in patient with shoulder impingement syndrome, and this is affecting the outcome of the patient. And this is not a simple procedure, just to come to make a procedure, acute pain to treat a pain. It may be a long-lasting pain, or just can lead for what's called an resistant post-operative pain. However, the shoulder have this focus of pain control, because it's a very big joint. It's not one joint, it's 4 joints, have a very big range of movement, and the coracoacromial arch usually squeeze the muscle down, and the blood supply is not as good as to regenerate all the shoulder joint muscle. But you must remember that position and surgery associated problem may be more important in management of those patients. And you must know that cerebral ischemia during shoulder surgery, and there is a case series about mortality and morbidity with sitting position, and cerebral ischemia happens, robotic evidence, adverse surgical outcome. And the surprise that most of the pain, shoulder pain, is not traumatic, not vigorous trauma. Most of the time it is a repetitive trauma, or just what's called tendinosis, not a tendinitis. Because tendinitis means inflammation, and most of the time it is a tendinosis, means a degeneration. And most of the time, you have a problem, because you know, if you feel your pain, you are as called a human being. But sorry, if you are alive, but if you feel the other pain for the other people, you are a human being. So we are agree as that multimodal analgesia is a very good procedure to go for regional anesthesia, non-steroidal, acetaminophen, opioid, and pharmacological adjuvant. And every method has its own problem and its own advantage and disadvantage. So what is the goal of analgesia? To improve perioperative outcome. You can't leave a patient with pain all the time. Decrease post-operative pain and related complication from the medication and from the pain. And prevention of peripheral and central sensitization to prevent the conversion of acute pain to chronic pain, and to make them persistent to post-operative pain after that, it will stay forever. And decrease the drug-seeking behavior from using a big amount of narcotics. What about the prevalence of shoulder pain? Shoulder pain is found in 7% of the cases collectively. But in older patients above 70, it is 26%. And above 80, it may be higher. And the pain usually moderate to severe, not a mild pain. And shoulder surgery is one of the worst pain you can imagine. But don't forget all the time the referred pain, because it may be a cardiac attack, it may be a problem in gallbladder, it may be an ectopic pregnancy, I refer to the shoulder, it may be a heart attack, as I told you, polymyalgia rheumatica. And second thing is that many organs can give you shoulder pain. So don't ignore that, because we have a case was treating as shoulder pain. At the end, we discovered the patient have myocardial infarction post-operatively. And there is also other referred pain, like whiplash injury, fracture humerus can give a referred shoulder pain, rupture muscular tendons, bicep tendon, or just other tendon, radicular neck pain. And usually radicular neck pain follows the shoulder like its shadow. And many cases I see in my clinic, it is just a shoulder pain, but misdiagnosed as a radicular neck pain, because they found some positive finding in the radiology, but at the end it is a shoulder pain. Thoracic outlet syndrome, diaphragmatic irritation, and liver disease. And I think most of us remember this picture when just Ramos attract the shoulder of Muhammad Salah, and you can see he's crying from the pain. But after pain control and rehabilitation, and he get a reward for that, because he don't have a pain. If you have a pain, you don't have anything to do in your life. And to remember that the neck pain, shoulder pain follows the neck pain like its shadow. All the time, if you have a neck pain or radicular neck pain, you must differentiate from the shoulder pain. And by many tests, like hand on head test or pocket test, or just a scarf test. What is the history about this chronic pain? You know, this is before the history when we can surgery without any anesthesia, like Grandpa. They make an amputation for him in 40s without any anesthesia. And this is inhuman, really. But this is the point we start the anesthesia to be mixed sleep in the patient to make anesthesia. And what about the history of regional anesthesia and shoulder surgery? In 1886, Kohler provided cocaine first time for regional anesthesia, for local anesthesia. In 1902, George Carroll describes the open brachial plexus, but really I don't know how can you make an open without anesthesia to instillate the medication inside. In 1925, first percutaneous successful block for Etna. The history started with when he made in 1970 a landmark technique for interscalene block, and it was a successful, and make it give here the description unilateral spinal anesthesia of upper limb. After that, the ultrasound technology and nerve stimulator coming to the surface. The history started with Winnie technique, which was a landmark technique, very high volume, 30 to 50 mil or 40 mil. After that, nerve stimulator and ultrasound came to the surface. What about the anatomy of the shoulder? The shoulder joint is not one joint, it's 4 joints. And I just show this paper about the anatomical and clinical study of suprascapular axillary nerve block for shoulder arthroscopy. And the date 2011, because after 2009, just try to revise everything. You know that the gray is the Bible of anatomy is done only after dissection of 12 body. But when you make a multicentric study with thousands of cases, you found many, many variations. And they found that the suprascapular nerve and axillary nerve, this is the main supply for the shoulder, can make a block. Also, and again, believe capsular nerve group block for both to shoulder pain, and cadaver study is done 2020. This is just last year, and nothing is fixed. So the shoulder joint complex, it is a complex joint. It is a 4 joint, sternoclavicular joint, scapulo-thoracic joint, acromioclavicular joint, and glenohumeral joint. Really, it is a 4 joint, and most of the time you have many, many problems in all the joints. You don't very rare to have one joint affection. So it is a joint bone and attached by ligament. There is some muscle bypass and what's called fixing the joint in the girdle of the humerus in the girdle. And there's many muscle like a rotator cuff muscle, which is supraspinatus, infraspinatus, teres major. And this muscle mainly have a problem because they have a very low blood supply and subjected for stress all the time and very big movement. There is some also muscle can support it above this muscle, many supplementary muscle. And there is also many muscle just bypassing the shoulder like scalene, trapezius, rhomboid, major, levator-scapulae. Why am I telling you that? Because every nerve, as Hilton law, every nerve bypass this joint can give a branch for supply for the joint. So the sensory for the joint is C3, C4, so the cervical plexus, supraclavicular nerve, C5, C6, brachial plexus, like suprascapular nerve, and upper trunk, suprascapular, as I told you, posterior cord, axillary, minor sensory innervation, and some type of value in some patient, like dorsal scapular, musculocutaneous of the arm, intercostal brachial, long thoracic nerve can share for the joint. The most important nerve for the supplying the joint is suprascapular nerve, which supply a very big, about 70% of the shoulder joint, lateral, superior aspect. And you know, blocking this nerve, we can give you a very good analgesia postoperatively. And there is another nerve which is called axillary nerve supplying. But you know, this many studies showing that it is not a simple distribution. In many studies showing that divided to 4 quadrants, and every quadrant supplied by different study because the anatomy is not fixed for everyone. But the main nerve supply is called lateral pectoral, medial pectoral, longithoracic nerve can share, also suprascapular nerve, dorsal scapular nerve, and axillary nerve. And this is a map just to show you how to the nerve supply, but this is not a fixed also, different from patient to patient. So what is the common indication for shoulder surgery? Really, it is not a trauma. It is what's called the rotator cuff surgery or just arthroscopic surgery. And many surgery done for inflammatory, like a septic problem, arthritis, maybe for reconnection, infection, many indication for the surgery. But the most important, that is called tendinosis, or just what's given name before, arthritis. So can we get this? Can we treat a patient with shoulder pain and we get this and to move your shoulder like this after surgery? Yes, we can. So first I will speak about general versus regional anesthesia. So whatever it is in general or regional anesthesia, the most important is safety. Safety is a paramount for the procedure. So what is the difference between general anesthesia and regional anesthesia? What is general anesthesia, safety is more higher because you put a tube and you control the patient. But in regional anesthesia, it may be for morbid sick and it may be converted at any time for regional anesthesia. Post-operative analgesia is more better than for regional than general. airway better control, but for regional anesthesia questionable. Post-operative range of movement poor with the general anesthesia and improved with the regional anesthesia. Opioid consumption and drug taking behavior higher in general anesthesia, lower in regional anesthesia. Just let me to give you this case. I don't need a solution now, but I will tell you this is a case, is morbid obese. She have a 40 cigarette smoking per day for many, many years, and just come for elective shoulder surgery. Her oxygen saturation is 90 in recovery room. She's in medical stable. She has a Malambati 4 and kyphotic fixed cervical spine. What is the regional anesthetic technique you can offer here? Really, we have a debate all the time. Just to make it regional anesthesia for this lady, and 90% will pass, and 10% it can need for example, an emergency intubation, which is devastating complication in this patient, or just to start from the beginning by fiber optic and to do the anesthesia to fix the airway and to do anesthesia for her. And I think there is a debate between everyone. If I open a debate, it will be a debate for everyone. This is according to experience, according to the facility of the hospital, according to the outcome, looking for outcomes of the patient. So what about the first method you can use for general anesthesia? So systemic analgesia. It is a very easy to use by everyone. Don't need a long-term training, but you need to know everything about your medication. It is a part of multimodal analgesia. Patient maybe need an opioid for few days, and may need as well continuous infusion for opioid. The concern about narcotic use and the drug seeking behavior, this is very important. Increase the incidence of cancer and persistent postoperative pain with general anesthesia. Advantage of the regional anesthesia, more pain control, as I told you before. Decrease blood loss most of the time. Improve cardiac and respiratory function because don't use a tube and don't make a muscle relaxation. Shorter stay in PICU in many studies. Ultrasound technique improve its use. Use experience, ultrasound experience decreasing the time, doses and complications. So it is not an one-way management. It needs what's called formal training for that. Disadvantage for regional anesthesia, there is some failure even the best hand, and no one just have a success 100%. Not long lasting, and after that they need narcotics, maybe narcotics, or just to put a catheter or to use a liposomal bupivacaine. Need a professional training program. It needs a training program. Even our fellowship has 3 years for regional anesthesia. Can't be used in every patient. It is not one fit all. The need for some equipment like ultrasound or nervous stimulator. Many questions not to be answered about regional anesthesia. What is the maximum dose? What is the best procedure for the block? So advantage of surgery under unconscious anesthesia, decrease the airway and respiratory cardiovascular complication. Avoid hypotension because anesthesia doing hypotension, and there is a very great difference in blood pressure in arm and brain and bed chair position. Reduce post-operative nausea and vomiting. Faster recovery. Efficacy, saving the time to institute and the resources. Increase engagement of the patient in his management. But you must know that it needs a training, as I told you. Even Mr. Bain with training can be like this. So anesthesia and analgesia for shoulder surgery. The first block can be done with a gold standard interscalene block, superior trunk like C5, 4, 5, and 6, supraclavicular nerve block, supraclavicular brachial plexus block, axillary nerve, suprascapular nerve, costoclavicular, infraclavicular block. Infraclavicular, yes, many study can be used. And also, what is the advantage of to make a block under WIC surgery? Also, there is many nerves you can use it to improve your pain control, like long thoracic nerve, lateral pectoral nerve, musculocutaneous nerve, intercostobrachial and medial brachial nerve, erectospinal and paravertebral block. There is many study for all this stuff. Local infiltration and subacromial subacute bursa injection and catheter. And everyone have its own advantage and disadvantage. What is the most effective method to prevent the postoperative pain? Not to do the operation, but this is a silly answer. You must do the operation. So the gold standard is interscalene block, and this is the anatomy. You can see like a traffic sign, and between anterior scalene, medial scalene, you can just go to make a block and easily. And this is one of the most successful block with even without ultrasound. You know that you must remember that in your trajectory, two important nerves, dorsoscapular nerve, you can be injured, and second nerve, long thoracic nerve, this is anterior scalene. And second thing, you must look for the bifid C6, because sometimes you inject in C6. And this is the anatomical picture, cadaver, and this is how to see in ultrasound. Because really ultrasound is a little different from the anatomy. Anatomy is like a negative picture for ultrasound, you know. So how to make it? Like before everything you ask you and neck is the C6, but really we do below the C6, because at C6 you can block the phrenic nerve most of the time. But I just will give you a very, very important thing about technique intrascalene, supraclavicular short axis view, and tilt the probe to see what's called traffic sign. This is one of the methods, or just to go from up and down. There is many methods to show it. But you must look for dorsal subscapular artery, dorsal scapular artery, long thoracic artery. You can see here in this picture, sorry. You can see here, this is a nerve. And sometimes you found here, this is another nerve, is long thoracic nerve. So take care when just you go to make an suprascapular artery injuries. And there is many case report about that. A long thoracic nerve can be injured, vascular structure like inferior thyroid artery, serpentine, what's called a vertebral artery, and the other nerve bypassing the plexus. Typical bifid C6 nerve root and phrenic nerve. Because most of the time, if you look for anterior scalene, you can find the phrenic nerve here in this area. But and just you join the plexus at C6. So if you make it below C6, it will be more easy for you. And you know the successful 100% block for the phrenic nerve will not happen. So risk, this is a paper from, I think, Korean Journal of Pain about the injury of long thoracic suprascapular nerve. And here they give you the nerve in your trajectory, so take care about it. And this is a pleura, anterior scalene, middle scalene, and this is a long thoracic nerve. But this area is very dangerous to make it. And this is how to make it, how to isolate. And this is the nerve distribution for the interscalene. What is the complication? We started from the up to down, like this, a neurological symptom, it can happen. A cardiovascular problem, like was lost anesthesia, making cardiac arrest, respiratory phrenic nerve. Before it was 100% because we're injecting about 35 to 50 ml, but now it's very rare. It can be with ultrasound. When you see the nerve, it can be 30%. Also, Horner syndrome, and you must inform the patient about that, because sometimes he feel abnormal feeling, and you must inform him about this. And also recurrent laryngeal, superinaryngeal, he feel like a lump in his throat. And look at assess systemic toxicity. Whatever to happen to the patient, you must put one of the differential diagnosis, intravascular injection, which 1 ml can make a convulsion, and nerve injury, and vital structure injury like thyroid or trachea or whatever. So how to decrease this complication? Use of ultrasound, but we need more data to prove that. Neurostimulation, it may be help, but we don't have a fixed solid data about it. Minimize needle passage and don't make more trauma. And a weak patient, because if anything happens, he can inform you about it. Needle to nerve distance, very important. You don't need just to go to enter in the what's called to enter in the nerve. Just even with the nerve stimulator, you can be about half a centimeter from the nerve, 1 centimeter. You can make a complete block. And to take care about injected pressure, not to go for more than 15 kilopascal. And you know that the aim of argument is of discussion is the success, not the victory. So what about the evidence? You know, according to our recent study, marriage is the main reason behind divorce. And absence of evidence not means the evidence of absence, because it may need more study, or sometimes the study is very difficult to be done. So supraclavicular plexus block versus interscalene plexus block for shoulder surgery. I made analysis and the clinical control trial. And they found there is no difference in analgesia. Even the supraclavicular make an lower incidence of complication. Supraclavicular block in obese patient, analysis of 20 blocks. And they found supraclavicular block may be successfully performed in obese patient and is associated with few complications. Suprascapular and interscalene nerve block for shoulder surgery. There is no difference, and this is 2017. No clinically meaningful analgesic difference between suprascapular block and the interscalene block, except for interscalene block providing better pain control during recovery room stay. Comparison of ultrasound-guided supraclavicular and interscalene plexus block in post-operative management for arthroscopic surgery, and they found no difference and maybe an alternative block for the shoulder surgery. Analgesic efficacy of ultrasound-guided interscalene block versus supraclavicular block for ambulatory rotator cuff tear. And also what's called the supraclavicular block is effective at interscalene block and decreasing the morphine use. So just go with the nature all the time. This is not my picture. You can look for this paper in 1991, 100% incident of hemidiaphragmatic paralysis associated with interscalene pelvicular plexus block as a diaphragmatic by ultrasound. But you know, this is in 1991, and during injection of very high volume. Now it is about 30% of the most of the study because we're injecting about 4 mil or 12 mil or just a maximum 15 mil. And it can make a very good analgesia, like when you're injecting a very big amount. Permanent diaphragmatic paralysis after shoulder rotator cuff, interscalene block is not on the factor, but usually incriminated about the factor. And it is a patient-related, surgical-related, anesthesia-related, but all the time you're lifting the mistakes of the surgeon or even the patient. Acute and acute complication associated with interscalene block and shoulder surgery, this prospective study. And it's showing that the incidence of short and long-term complication is 0.4 in case of persistent paresthesia, dysesthesia, and patient related to surgery, interscalene block. And because of that, they're thinking seriously about another block which given less complication and at the same time give a very good analgesia comparable to interscalene. So this is a phrenic nerve and diaphragmatic movement. When you make a block, most of the time you have a very low diaphragmatic movement and vital capacity can decrease 25%. And most of the time I look for the diaphragm when I make a block. But very rare for the patient to complain. But still, some patient complain, even adult, when you have a predominate on the nerve, phrenic nerve on the side, and some patient need a very long term, about a few hours for oxygen. So this is how to make the ultrasound-guided suprascapular block and posterior technique. There is many technique, but you must know that what's called suprascapular fossa, and there is a nerve and artery here, which is pulsating, and you can just go trapeza supraspinatus to inject it here. But you must care that 10% of the patient you don't have this fossa, and the nerve already passing through the bone. So you can make an spinal. This is one of the injection. You can see the fluids, and this is a variation, and every time because they don't have a fixed anatomy, as I told you, there is an interview about suprascapular nerve, many variation. But if you feel to do that, you can just go more posterior below the spinous process to make an what's called in spinoglenate fossa, and you can see the artery and at the same time your nerve. But you must remember that the ACCI nervation passed in this area. You don't make a block for it. And there is an anterior approach for suprascapular nerve. You can make it because this is the main supply of the joint. And this block need about 3 to 5 mil. And very little complication, and in comparison to other block, it can give a good block. I make it many times, and this what's called fantastic result. And this is the most lateral nerve. You can find it with superficial fascia and peripheral. And when I take off from the lateral take off from the supraclavicular plexus. Here it's called what's called an inferior belly of omohyoid, and you can see the nerve here all the time. And usually don't mix a black bubble in the neck because the nerve in the neck is black. So you must put a colored Doppler, it may be an artery. So take care about this. Huh? So here you can see another picture for suprascapular nerve, anterior approach. And there is many studies to support that randomized controlled trial comparing respiratory and analgesic effect of interscalene, anterior suprascapular, and posterior suprascapular, and they found the anterior suprascapular more effective and low volume and less complications than the other one. Another nerve is the axillary nerve, and you can just, this is a landmark technique, surface landmark. You go for acronym from behind, and at the axillary fold, you can put your a needle to inject here or nerve stimulator. But with ultrasound, you can see it early because there is a circumflex artery. You can see pulsating and nerve usually beside this artery. And this is the anatomy. You can make it longitudinal or transverse, no difference. It's transverse picture. What about cervical plexus block? Because you know cervical plexus just going until C2, so T2, T2 or maybe 3. So just supplying the anterior surface of the shoulder. And you know that the cervical plexus block is composed of transverse cervical, greater occipital, and what's called greater auricular, lesser occipital, and supraclavicular, which is many nerve, lateral, intermediate, and medial nerve. And you can make a block for this superficial cervical plexus. Most of the time, if I ask you, they said C6, but now this is C4. This is C4. How do you know C4? And more effective here, you can find the artery dilated, about to be bifurcated. The the carotid artery. And you can see the greater auricular. This is a big nerve. You can see get around the sternocleidomastoid. You can see it's like a two nerve. And the two injected just below the sternocleidomastoid, 5 to 15 mil, usually more than enough to block this area. And here you can see that. And here you can see the interscalene block. And here, just below the acute edge of the sternocleidomastoid, you can just block it and to get an superficial cervical block. Moreover, you can just go for upper trunk because you know the superscalar come from upper trunk like C5 and C6, and you know we learned that from the transfemoral injection for pain management. But they can make it for the injecting a low volume, and you can get a very good result from the. You know that I just make it 2 days ago for a patient and was in miserable condition, screaming, and became silent. And but I put a catheter for him because it was a very fragile, and he stayed 3 days for a catheter and was very good. When I make it just C6 and C5 nerve root. Superior trunk severe shoulder surgery anesthesia alternative to interscalene block for patient with compromised pulmonary function because you don't inject a very big volume away from phrenic. Again, here you can see here, this is the C6 anterior tubercle, C5 and C6. You can inject it here, a very low volume. And here also 5, 6, and 7. So in some cases, we need more analgesia. And this paper is very interesting. Does the cervical anterior plane block or longithoracic nerve block add to interscalene block improve the quality of anesthesia in arthroscopic surgery? And there is the answer, yes, it can improve the quality of analgesia for the, and you know that how to make an interscalene block. Here, the superior trunk. Also here, you can see what's called the medial pectoral. This is a BIX1 and BIX2. So medial pectoral in some patients given a very big contribution. And when you see here, because major, minor, and you're looking for descending branch of cervical artery, you injected it here of about 7 mil, 10 mil, it can make a very good analgesia for the shoulder. Here, that's a cervical anterior plane block, or just you can block the nerve along the thoracic and the anterior scalene, or even between the scalenus medius anterior on the pleura. You know that there is also can make another selective nerve block. You can make an supraclav for all the time, and you can make it easily by ultrasound. And also infraclav, which is costoclavicular technique, because costoclavicular technique is the more medial to the block, and most of the bunch of the grape is found lateral, like supraclav. And many case study showing that it give a very good analgesia. What about the unique block, this electrospinal plane block for proximal shoulder surgery? This is a phrenic sparing technique. It can be used, and in many study a case report about and case series about what's called as one fit all. It can be done thoracic, it can be cervical, it can be a lumbar, it can be even it can be an sacral. So the cervical electrospinal block catheter for shoulder disarticulation surgery, and you go to the transverse process of C7 and you injected your fluid, and it worked in a very good ways. And this is case you can see the catheter. So local anesthesia for electrospinal interscalene groove and paravertebral area, and this is the mechanism of action. Phrenic nerve sparing technique. Theoretical risk of phrenic nerve paralysis still present and vertebral artery injury. So this is how it works when injecting CT or with gadolinium to see how the mechanism of action. I will leave this paper because you know the main contributions what's called an multimodal analgesia. And this is a very interesting paper about the effect of local anesthesia volume 20 versus 5 mil on the efficacy of respiratory consequences of ultrasound-guided interscalene block. They found no difference in analgesia, but there is a very great difference in the complication. Also, you can make a peripheral nerve block for analgesia for arthroplasty. It's 2020 paper, and the peripheral nerve blocks used in shoulder arthroplasty is a very effective method. I have a case 2 days ago about the Mecan total what's called the shoulder arthroplasty or replacement, and the patient have a severe pain, so you can't go for injection for the joint. I make a suprascapular and chronic pain and axillary nerve block for her, and she see first time 3 months without pain, very minimal pain, and she came again. I make her block again, and she's still for a few days very good, and she's appreciated what we did for her. Pre-articular infiltration is a novel technique, but we have a problem with the cartilage. It can be mechatotoxic for the cartilage. And the second thing about that, it can stay for a very short time, 2 hours, 3 hours. And you need a very professional surgeon to do that. And toxicity is very high. It's very high. There is a case report about ultrasound-guided infraclavicular Blexis blocks and suprascapular nerve block for the shoulder surgery. And the infraclavicular, what's called the costo-cervical technique, it can be used, but still in a case report, not on a randomized controlled study. There is many evidence about the protocols and about the methods about catheter in the subacute subductor bursa. And now in 2020, you found that joint replacement in primary hip, knee, and the shoulder, it make an evidence-based guidelines in June 2020 about how to use different method for regional anesthesia or different method for analgesia. And the guideline just so it is a spotlight on the road, can guide you for the best. So regional anesthesia for a 60-year-old patient with hypertension, I just will ask this question, you don't need just to answer. Coronary disease coming for shoulder arthroscopy. List is an optional regional block for shoulder surgery and their complication. Identify ways to avoid complication. Propose surgical position for shoulder surgery and their consequences. Formulate post-operative treatment for pain. I don't need to answer, but there's must be thinking about it, And I know most of you is very professional. You can just solve this puzzle. But I'm scared about the distal learning to be the result at the end like this. So I know that time is squeezing and I must finish now. I just remind you about this case also. Morbid obese, 40 seconds per day, come for shoulder arthropathy, and you have a Mallampati 4, and saturation is very low. What's your option for the analgesia and anesthesia? It's my message to you, all of you. A bit shear position is carrying the major risk for the surgery. Updating our anatomy knowledge, you must update your anatomy because there's a variation. Learn a new block all the time. You must learn a new. Shoulder surgery associated with severe pain. Don't take it easily. Regional anesthesia can be used to give anesthesia, analgesia, and anesthesia. Electrospiny brain block is still the gold standard, even with a complication. Selective peripheral nerve root block and root block is maybe alternative for intrascalene block. Operative pathway should integrate based on education, intraoperative multimodal analgesia. Regional or general anesthesia, safety is paramount. I don't care, but safety is paramount. Ready for complication to discover, to treat. We don't know peripheral nerve with ultrasound become more safer than before or not. We still need more data to show that. As absence of evidence is not an evidence for absence, you need more study, and sometimes that study is not ethical. And we remain in the infancy of the trial. And publish is only one side of the coin. It may be a professional one to bring a result and non-professional one bring another result. We need to answer many questions, the optimal volume, the optimal drug, and the optimal technique for the surgery. And I hope, inshallah, next year, we don't go for plain like we're just going to ICU. And at the end, you must know that a doctor is a student till his death. When he fails to be a student, he dies. This is Sir William Osler. This is a physician and writer, Canadian writer. Thank you very much for your attending, and any question and answer.
Thank you very much, Dr. Yasser, for this nice illustration. I didn't have any questions in the box, but I have a question for you. So you have mentioned a lot of regional anesthesia techniques. What's the standard technique you do in your institution?
Really intrascalene is still the gold standard. But in some cases, you must care about the phrenic nerve, the fluid not going to the phrenic nerve. Or in many cases, if you found the phrenic nerve is very near to the plexus, just go for upper trunk, C5, C6 to inject it. And many cases also still, if you have like a shoulder replacement, I just make it far away because I can't go near the metals, as the surgeon don't like that because it may produce infection. So I go for suprascapular back technique, and also the axillary technique, and it works. And the good news about the chronic pain, it works for many months. This is a very good thing. It's not like acute pain. I don't know why and how. Like a genicular nerve, you can see for many months, and this is a very good thing for the patient.
And as a technique for anesthetizing shoulder surgery at your institution, do you use combined anesthesia, intrascalene block plus general anesthesia, or just intrascalene?
Really, in many cases, we use that. if the patient not cooperative. But if the patient cooperative and he needs regional anesthesia, we make many cases by regional anesthesia only.
Okay.
And usually we put a catheter.
And normally they are in the sitting position, so for safety.
Sitting position, yes.
So for safety, do you give sedation or do you give a general anesthesia?
No, some patients don't need any sedation, and some patients need a sedation. But a very light sedation, usually we use a very minimal dose for dexamethasone because we don't lose the upper respiratory tract intubation. And in many cases it works, and in some cases you need to intubate the patient. This is according to the preference of the patient, the surgeon. And in many cases, sometimes the patient asking, I don't like to sleep.
Okay. And how much volume you give of local anesthetic?
Usually I give 12 ml, maximum 12 ml, from 10 to 12 ml. And the position of the needle is more important than the volume. So sometimes I inject what's called witness distribution. Sometimes I inject about 5 ml. I found soaking or flooding the brachial plexus interscalene, so I don't inject more. But sometimes I found still some area not flooded, so I injected more. But maximum 10 to 12 ml, more than enough.
And you do the interscalene block in the regional anesthesia block bay before you get the patient to theater?
Sometimes if the room is empty, the block room come to save the time. If this patient is still inside, I just can make a block and test it in block room. But if the room is empty, I can make it in the block in the operating room.
Okay. One of your patients is suffering Horner syndrome and hoarseness voice after giving interscalene block.
Yes.
How you are going to endorse that to the patient?
Yeah, really, you must teaching him before that. You must teach him, not just when it happened. You can tell him all the complication, 1, 2, 3, until intubation, it may be failed, and you can feel a lump in your throat. You can see Gitten Horner syndrome. And if the patient, what we found there, if the patient know everything about the block, he accepting everything. But the problem, if you don't tell him, you have a problem with that.
Okay. Now I got some questions in the box. So from Ahmed at Tawansi, sometimes the surgeon requests examination of the upper limb nerves after surgery. Is it safe then to give interscalene block, though as intraoperative analgesia?
No. We are one team. Usually we make it post-operatively. If the surgeon says that there is an even fracture or anything in the shoulder and may have a nerve injury, don't put a needle inside. And tell him if that usually I tell the patient, the surgeon, post-operative, you can test your patient and make a block after that and document everything. But don't make anything against the wish of the surgeon because you are incriminated all the time.
Okay. Another question: the safe volume local anesthetic and what drug in interscaling to avoid its complications?
As I told you, there is many questions to be answered. What is the maximum volume? What's the best volume? What is the best drug combination? We don't have this answer, but everyone just make an effort to have an experience with that or to make a study. But for us, that if I have an anesthesia, just I give 0.5 levobupivacaine from 8 to 12 ml all the time. For analgesia, ropivacaine is a very good drug. Sometimes I give dexamethasone with the medication or just a corticosteroid. And if the surgery will continue or just need what's called severe pain, I put a catheter. But really, we don't have a liposomal bupivacaine. I have this one in some hospital before, but we don't have here in
the preservative-free. You mean, yeah?
Yeah, no, not just preservative-free. Liposomal bupivacaine, which you can stay for 3 to 5 days.
And like, do you go for? If you have it, you will do it for 3 to 5 days?
Yes, I do. I tell you, this is not approved by FDA, but when I speak with you now, about 8 million American, this medication used for him.
And how you will follow up your patient if the local anesthetic?
We have an acute pain surface, a team here. I put the list on my list, and acute pain surface following the patient until he discharged from acute pain to discharge. Pain surface.
Will you keep your patient for 3 to 5 days in the hospital blocking a bed, which is really expensive and costly?
No,
don't. The local anesthetic effect wears off. Yeah.
We don't do that for all patients. For arthroscopy, it is an 1 day or 2 day block, But some cases need an rehabilitation in the hospital. This is different from patient to patient. This is not an one fit all. This is not an one operation. It may have been an operation on the shoulder. And really, as I say, you said, this is can consume the resources, but most of the patient discharge, you know, the TKR here was our hospital here discharging the same day or second day, not to stay for 5 days, fast tracking. And
usually
send them for physiotherapy,
yeah. Will you require 3 to 5 days block, nerve block, and because usually the peak of pain is in the first 24 hours, will you require 3 to 5 days nerve block for a shoulder surgery?
No, not all the time we use an regional anesthesia. This time put a catheter and she'll remove it second or third day, or sometimes send the patient with some narcotic like tramadol or non-steroidal because it's a multimodal analgesia. This is a problem with regional anesthesia, as I said. It is not a continue if you make one injection. And if you put a catheter, sometimes you put a catheter and send the patient home. And some patient, if he's highly educated, you can give him a machine. We have a patient working in an ambulance. He uses his what's called an infusion pump with him in house, and many patients doing like this. And they will just inform him, and we give him like a pamphlet for anything to happen, just to come to the emergency.
And is it a safe practice and common practice in Hamad
No, not
Medical
a common
Corporation?
practice. Not a common practice. Not a common practice for selected patient. Yes.
Okay. I have a question here in the box. The safe volume of local anesthetics and what drug in interscaling to avoid its complications?
You know that what I'm telling you is that this study now, what is the minimum effective volume? 95. And if they found for interscaline and 8 mil. This is 95%, I can block it with 8 mil. And if you want to make it 100%, you can just give half of this volume, it is 12 mil. For supraclav, it is 18 mil. But if you wanted to make a complete block, in most of the cases, it can be, but still, this is a primitive study in the beginning of the study. So what I said, you have many questions to be answered. What is the optimal dose? What is the optimal drug? What is the optimal infusion? What is the, you know, still we need more study, you know?
The last question here, Dr. Yasser, a patient coming for arthroscopic rotator cuff repair, what is the analgesic plan you do?
As I told you, it may be making one injection for regional anesthesia, or just put a catheter if it is a very aggressive operation. The patient can stay for 2 to 3 days in the hospital, or if the patient can discharge it and with an, you know, after 24 hours is the maximum pain, I can just send home with some analgesia and to follow up in the acute pain surface with a painkiller.
Thank you very much, Dr. Yasser.